So what would be your next investigation, or would you go ahead to treatment?
So the next investigations here, we consider histological diagnosis using a liver biopsy to try and ascertain whether this definitely was autoimmune hepatitis. And then the mainstay of treatment for this patient would be steroids.
Okay. And longer term, what else could you use other than steroids?
So longer term, other than steroids, after you treat an acute phase, you think about other immunosuppressants. So other immunosuppressant medication. I don't know particularly which ones.
Registrar. And the key thing here is to be systematic about everything, which was very nicely done in the scenario. Assess the patient in the first instance, make sure they were okay. Try to glean out a bit of the other symptoms from the history, as well as try and work out if there's any indication of chronic liver disease and whether this jaundice was a decompensation presentation rather than an isolated liver injury, which is good. Systematically going through the rest of the history was very good. Looking for any other things in past medical history that might be important: drug history, alcohol history, family history, etc. was very well done. And then looking at the differentials, splitting it into a prehepatic, intrahepatic, and posthepatic cause is a very nice way of doing it, and shows that you have a understanding of the physiology, but also a structure in place to assess this kind of patient. The differentials were good. The initial investigations were very good as well.
I think certainly the IMT3 experience helped me a lot, because in the DGs that I'm working, the IMT3 is definitely not a transition period. You're literally working as a reg. You're the only reg on night shift with no other senior registrars around. And it also helped that I sort of requested for a gastro job specifically for my IMT3 to my TPD, because we got to sort of put in a personal statement for our IMT3 posting. And so I sort of specifically requested for a gastro post in a DGH so that I could sort of start acting up as a gastro reg early on. And I think that significantly helped me in my interviews, because most of the questions I had sort of somehow was related to my personal experience I had in my 6 months of IMT3 in gastro.
Are you talking about the clinical station or other stations?
Clinical stations, med-reg stations. Yeah. I think because there was a huge, I think it's 37 marks for the clinical station, if I'm not
huge.
Yeah, sort of, yeah. So I thought that helped, because the case I had, I was involved in a similar case before.
Right.
So I think it was all pure luck as well. I was just lucky in that sense, but no, it all turned out well.
Yeah, I don't know if we can call it luck. You did very well in your interview. You scored full marks across the board and ranked top. So, I think you might be being humble, but I'm allowed to say that.
So we're going to just break them out into different categories just to make it easier. So the first sort of essential management is alcohol withdrawal, because obviously if the patients have a history of alcohol excess or dependence, so make sure this patient have CVAR score calculated in point of admission, and they start prescribed sort of short-acting benzodiazepine, lorazepam or oxazepam, depending on the trust that you work in, instead of diazepam. The maximum dose is about 240 milligram in 24 hours, and make sure that's get reviewed daily, as some of the patients may need regular sort of short-acting benzodiazepine if they do score really highly on the CVAR score in the first 24 hours. I think it varies from trust to trust that I've worked in, so it really depends on your local trust protocol. And making sure they get started on IV Pubrinex, TDS for 3 days as a sort of prevention of wernicase encephalopathy. And often this patient needs to be stepped down to a thiamine and vitamin B co-strong as a maintenance regime. Second biggest parameter will be a sepsis. As mentioned before, patients should have septic screen, and that includes an anesthetic tap as well. And then you start antibiotics if there's evidence of sepsis based on the source of a suspected source and your local guidelines, obviously. And if you're suspecting SPP, based on the acidic tap, it should be white cell count of above 500 or a neutrophil count above 250 millimeter per cube. And again, commence antibiotics based on your local protocol. And this patient should also be prescribed HARS, and the guideline says it's 1.5 gram per kilogram on day 1 and 1 gram per kilogram on day 3. And obviously not to give all the HARS.